two main objectives here today. First, I want to review some key previous studies that have explored the role of the coronary sinus reducer in treating refractory angina. And second, I want to discuss the study design of COSIRA 2, which all of us here are very excited about, and hopefully encourage you to find ways to enroll your patients. So the coronary sinus reducer is something that we've been hearing a lot about recently, but in reality, over 2,800 CS reducer patients have been studied dating back to 2007 from this initial study by Dr. Banai looking at 15 patients with severe angina and reversible ischemia. The study found that there was procedural success in all patients, and the patients were followed for 6 months with follow-up dobutamine stress echoes and assessment of their angina, and essentially noticed that in almost all patients, there was improvement in angina and ischemia at 6 months. There was a variety of studies in between, but I want to highlight COSIRA 1, which is an important study to go through here today to set the stage for COSIRA 2. COSIRA was the first multi-center, randomized, double-blind, sham-controlled safety and efficacy trial that demonstrated safety and effectiveness of the CS reducer. Its design was taking 104 patients with refractory angina with CCS grade 3 or 4, maximally tolerated GDMT who had no revascularization options, and basically randomized 52 to the reducer arm and 52 to a sham control arm. The primary endpoint that was assessed in this trial was the improvement of at least greater than 2 CCS angina classes at 6 months. And you can see the results of the study here. And it achieved its endpoint in that there was significant improvement in greater than 2 CCS classes in the reducer arm versus the sham control arm with the p-value of 0.02. And this was coupled with low 30-day serious adverse events. I want to take a second to just show visually the change in angina, and you can see the patient started with CCS 3-4, and by the end of the study at 6 months, the majority of them had moved to CCS 1 and 2, further illustrating the results of that study. The Reducer 1 study is also important to mention. This is a multi-center, open-label, post-market observational study, and we only have interim results right now, but this is essentially confirming safety and improvement in symptoms, functional status, as well as quality of life in these patients with refractory angina. This study includes 180 patients that are being studied prospectively, as well as additional patients that are being studied retrospectively. And as we look at the patients, you can see that the mean age is about 68, 69 years old. The majority of patients are male. Many of them have had a previous myocardial infarction, and many have had previous CABG, and this is sort of the patient population that Dr. Henry has already showed us today. But as you look at the percentages of previous CABG, previous PCI, hyperlipidemia, type 2 diabetes, and hypertension, you can see that these patients have high baseline comorbidities. 70% of patients had CCS 3 to 4 in the baseline studies here, and what you can see is that 17% had a reduction in their angina at 6 months, 70% improved greater than 1 CCS grade at 6 months, and the most interesting part of this has been the long-term follow-up, and what we can see here is that there's sustained CCS improvement out to 24 months, and that suggests durability of the results that we saw from COSIRA 1. So moving to COSIRA 2. COSIRA 2 is a randomized prospective double-blind sham-controlled trial. The PIs are sitting right here, Dr. Stone and Dr. Henry. And this study is randomizing 380 patients with CAD and refractory angina with CCS grade 3 or 4, maximally tolerated medical therapy who have no revascularization options. The study will be randomizing 190 patients to the coronary sinus reducer arm and 190 patients to the sham control arm. And I'd like to draw your attention to this down here. And so essentially at 30 days, 90 days, 6 months, 1 year, and at 5 years, CCS angina grade will be assessed. At 6 months and 1 year, exercise tolerance and angina diaries will be assessed, and then SAQ scores and quality of life scores will be assessed at 6 months, 1 year, and at 5 years. Let's look a little bit about the eligibility criteria and who is going to be included in these patients. So like Dr. Henry went over, this is going to be mostly patients with obstructive CAD with persistent refractory angina, CCS 3 to 4, despite maximally tolerated guideline-directed medical therapy of at least 3 drugs. Patients will have reversible myocardial ischemia in the left coronary artery circulation to be randomized. They should be deemed to have no revascularization options by the interventionalist that's presenting the case. Their modified Bruce protocol, they would go about 2 to 8 minutes, and they would have a normal ejection fraction greater than 30%. Key inclusion criteria is the study will not be randomizing patients who have ACS, patients with elevated right atrial pressures, or patients that have abnormal CS anatomy for obvious reasons. The primary effectiveness endpoint at 6 months is a change in total exercise duration on the modified Bruce protocol, and then the primary safety endpoint is the composite of death, MI, pericardial effusion, device embolization, or bleeding. Some key secondary effectiveness endpoints include change in angina grade, change in SAQ angina stability, at 6 months and 12 months looking at exercise tolerance and exercise duration, as well as angina frequency, and then annually through 5 years, as I mentioned earlier, looking at improvement in greater than 1 or greater than 2 CCS angina grades, change in SAQ scores, and then perhaps most importantly, the number of unplanned office visits, hospitalizations, and ER visits for angina. The study will also be looking at the number of deaths, MIs, stroked, and unplanned revascularization procedures throughout follow-up. A really exciting part of the study is looking at these various sub-studies and registries, so I'm going to briefly highlight this. There'll be a CTA sub-study that will be 50 patients to assess device position, structure, and function at 12 months. The PET sub-study was briefly covered already, but this is essentially to assess transmural perfusion, subendocardial perfusion, and absolute coronary blood flow at 6 months, and this will be 120 subjects in this arm. And then there's various single-arm registries that will also generate some thought-provoking data. The first is 110 patients who have RC predominant ischemia, patients with ANOCA, that as was covered before, non-obstructive coronary disease, this will be 110 patients, and then patients that are unable to complete an exercise tolerance test due to lower limb amputations, and this will be up to 50 patients. We're excited to announce that there's 30 activated trial sites right now, and there's a process that we'll discuss during the discussion in how these sites are activated and then how the initial studies are conducted. I'm going to briefly just cover these additional CS reducer studies. So some of these were already covered earlier, but there's a variety of studies looking at various patient populations, ANOCA and CMD, a few studies looking at refractory angina and obstructive CAD, and then another study here, and this data will be presented looking at ANOCA and CMD. But essentially, there's a variety of patient populations that can be enrolled into these studies, but not all will be randomized in COSIRA 2. Some key take-home points are first, several studies have shown efficacy of the coronary sinus reducer in reducing angina and ischemia in patients with no revascularization. COSIRA 2 is a randomized double-blinded control trial designed to assess whether the sinus reducer improves exercise tolerance in patients with ischemia and no revascularization options. There's several smaller ongoing cohort studies and randomized studies to assess the role of the coronary sinus reducer in improving angina and exercise tolerance. And we really need to think about enrolling these patients in these trials, as this is critical to advancing therapeutic options for our patients with refractory angina. Thank you.